Welcome back, class. We're going to spend a few minutes, and this is not going to be a long chapter. The information in this chapter is not that complex. It's fairly straightforward. You've probably gone over some of these issues, at least socioeconomic issues or societal issues, depending on how you want to phrase it. Maybe in some other classes you've had at Fisk, but again, their authors provide some valuable concepts and some valuable information, but it's certainly not going to be as much detail as what we had in chapter 10. And Gawars starts out in chapter 11 talking about U.S. leads the world in healthcare spending. I mean, that's depending on how many journal articles you've read or how many reports that you've read from the National Institute of Health or CDC. I think that's pretty much a given that we lead, the world in healthcare spending. But most, especially academics, will argue that quality is lagging. Quality of healthcare in the United States may be lagging behind the quality of healthcare that you can receive in other countries. And because of that, there has been, I don't want to say a boom, but there's been a significant increase in what's considered medical tourism. And medical tourism means that, at least for the most part, you're going outside of, at least in the broad definition, you think of medical tourism, you're going to another country to receive healthcare services. It hadn't been that long ago that there was a fairly significant increase in knee replacements, hip replacements, a lot of some fairly complicated surgical procedures that were being performed in the Orient or in the Far East, and a lot of health plans were taking advantage of that. Now, you can also look at medical tourism as within the confines of the United States. I was going to say within the more along the lines of the contiguous U.S. states. I don't know of many individuals that go to Hawaii for healthcare. They may go to Hawaii for healthcare, but it may not be healthcare, might not be the driving force. And there were, at one point, there seemed to be several individuals going south of the border into Mexico and maybe even farther down into South America or Central America for some of the healthcare services, but that's gotten extremely dangerous lately. So you probably don't see much of that, or you don't see nearly as much as you used to. At least it used to be in San Diego County, you had a lot of individuals going south the border for their dental work. They thought they got and maybe they did get as good as high quality dental work as they were getting in San Diego County, and a significantly lower price. But also medical tourism, and I'll just take cancer hospitals as an example. MD Anderson, huge cancer hospital in Houston. You've got City of Hope in LA. Fred Hutchison, I think his name is the hospital in Minneapolis. You've got some in New York City. You've got some in Maryland, and even Buffalo had Roswell Park, who Roswell Park considered themselves a destination hospital for cancer services, but yet there were more than a few individuals in Buffalo that when they needed cancer services, they didn't go to Roswell Park. They went into New York City for their services. But when you're talking about, Fred Hutch, and you're talking about MD Anderson, you talk about City of Hope, based on where they're located, you have a lot of individuals and health plans sending their more complicated patients to those facilities, and they are truly destination facilities for cancer services. Have you, if you've been watching television at all, you've been seeing advertisements for St. Jude's, Shriners Hospital, two huge, consider themselves not-for-profit, and then they're based on funds and endowments and donations, and supposedly the healthcare provided to those kids and and the cost of their families going. It's all taken care of by those two facilities. So again, destination hospitals, and to me, whether it's cancer or whether it's City of Hope or St. Jude's, those are medical tourism to me because you're not seeking your care locally. Again, talked about the safety issues in some of your foreign countries, and then you're focusing on health status. In the United States, we spend a lot of dollars focusing on our health status, and again, lead the world in healthcare spending, some kind of questionable quality. You've got a liberal view, and that's especially the far left, and they are concerned with insufficient income, earning opportunity. They want unlimited budget outlays for social programs, welfare payments, training and education programs. Again, I've mentioned before the EBT cards, the electronic benefit transfer cards that especially low-income individuals or maybe some Medicare Advantage individuals get dollars put on that, either monthly or quarterly for food and over-the-counter type drugs. You've got community clinics that are set up. And again, I think there's a community clinic down there at the corner of Jefferson Street and 14th. You've got Medicaid, you've got Medicare Advantage, especially the dual eligibles that are drawing subsidies from both Medicaid and Medicare. You've got, and a lot of it drives overutilization, a lot of it drives access issues for everybody, because when you look at access to healthcare, there's the amount of hard dollars that you pay, for your deductible, your co-insurance, your co-pay, and then there's the soft dollars that wear and tear on your car, or maybe you're having maybe it is a hard dollar if you're paying Uber, Lyft, or taxi, or riding the bus to the doctor's office. You've got parking, which again is a hard dollar, but you've got that soft dollar factor, which I've always called kind of the value of your time. So again, I've talked about it takes me between 2 and 3 hours every time I go to the doctor, and a lot of individuals on, I guess, limited income, or maybe they're unemployed, or elderly populations. They're, what is the value of their time? So they can go to a community clinic, they can, go to see the doctor, and it doesn't matter to them, as long as they can, as long as they have the transportation to get there, then they can, time, the value of their time is not, or at least their time, from my perspective, is probably not as valuable as mine. The other thing that you run into on some of these subsidized programs, and I saw it a lot in downtown Buffalo. There was a Rite Aid and a CVS in downtown Buffalo, and I would go especially into the Rite Aid and pick up my prescriptions simply because it was just closer. I could, from the apartment I lived in, I could walk. It was, I don't know, a block up the street maybe. I could walk to Rite Aid, pick up my prescriptions, and it was fairly frequently that I would go into Rite Aid and I would be in a line behind a Medicaid beneficiary, and when it came time to pick up their scripts, that the pharmacist would say, you're going to be able to pay your copay, and they'd say, no, I don't have the money to pay it. And the pharmacist would say, okay, and they would, ring them up, no payment, give them the script. As the individual walks out the door, they're, grabbing a couple of tall boy beer out of a cooler, going to the front, cash register, paying for it. And then you follow them out, and they get out on the street, and they turn around and they sell that prescription or sell that bag of drugs to somebody on the street for cash. So, a huge issue with overutilization, a huge issue with potentially black market for pharmaceuticals, especially some of the behavioral health pharmaceuticals. Then you've got the conservative view, and it's breakdown of family values. Government is a significant contributor to social pathologies. And they talk about feminization of poverty with government incentives driving this lifestyle. You've got individuals that the government is, it's a generation. It could be a generational thing that, generation after generation, it has become accustomed to government, subsidies and, being at the government trough and getting their subsidized food and subsidized health care. And it becomes, what do they call it, generational poverty or generational subsidies. So, passed on from generation to generation. And that there has to be something done about healthcare in the United States. It's just year over year, everybody talks about something having to be done. And I don't think anybody has come up with a strategy at this point to kind of change healthcare and make it a higher quality, lower cost alternative for all of us. And then Dewar starts talking about some of the episodic type of issues, and she starts out with HIV and AIDS, and she does say it has seemed to slow recently, with most being contained to specific HIV or specific IV children populations. All are at risk, but not equally at risk. And I think that is a determining factor about HIV and AIDS. So anybody with HIV and AIDS is definitely at risk, but may not all be subject to the same level of risk. And then she starts talking about, AIDS is primarily an inner city issue, disproportionately minority community based, large urban areas. I think more and more you're going to see as the homeless population just seems to be exploding around the United States. There may be an uptick. There may be an uptick in, not only AIDS and HIV, and I'm seeing instances with a lot of the diseases that we, thought we had eradicated in the United States. Some instances cropping up of, polio and TB. You've got a lot of individuals coming in through the southern border. And, you don't know what their immunization records look like. You don't know whether they've had any preventive care anywhere along the way. You don't have a clue about their health status. Don't know what kind of health issues or episodes of health care, flowing in with that population. And again, it used to be a lot of individuals were concerned about the homeless population. It was somewhat a manageable homeless population. A lot of the individuals appeared to have been veterans, or they've been some type of in the military for some reason. So, but a lot of, and it was a transient population. But now it's just like a lot of these cities, the homeless, the homeless camps have just taken over. You've got tent cities and a lot of your inner cities that have just completely taken over. And these sanctuary cities now are concerned about who's going to finance the population of individuals coming up through the southern border. So if policymakers think there has been a drain on healthcare in the past, what do you think the drain on healthcare, especially from a policy perspective, what do you think that drain on healthcare is going to be going forward? And then she talks about HIV requires access to the bloodstream and bodily fluids. And typically you're talking about drug use and sexual behavior are primary determinants of risk. FDA, CDC drive drug therapy and overall reduction of healthcare costs per person. And that is true. FDA, a lot of these high-cost drugs have to be approved by FDA to get on the market. It is, again, we talked in chapter 10 about lobbyists and, special interest groups. And, how many lobbyists do you think are lining their pocket with dollars helping pharmaceuticals, especially R&D pharmaceuticals, get these drugs pushed through FDA and getting them on the market? Government sources, public programs, clinics, hospitals, Medicaid covers a disproportionate share of healthcare costs. And when you talk about a disproportionate share of healthcare costs, not only does that Medicaid population and be driven by a lot of factors, but not only does that Medicaid population consume a lot of healthcare goods and services, but Medicaid, from a provider's perspective, only pays a small portion of the cost. Medicaid has for years been, the payer of last resort, and providers more and more are kind of shying away when you've got a medical group and they are accepting patients. It's not out of the ordinary anymore to see practices closed to Medicaid patients, practices closed to Medicare Advantage patients. They're going to make more money on the commercial health plan side of the house, so that's where they want to focus their dollars on. And because of that, you're going to see fewer and fewer opportunities for Medicaid and Medicare Advantage populations in a lot of these medical groups. My guess is that not only the clinic down at the corner of down the corner there of 14th Street, you're going to have maybe an influx, and every time I pass there, that parking lot's packed. And I've talked to individuals that at Meharry, or that worked at Meharry, or have are currently working at Meharry, and they have a lot of grants to provide goods and services to the indigent population, but they are overstrapped right now. There's not enough scarce resources to go around to provide the healthcare goods and services to all of the individuals that require them in that Nashville area. Drug-resistant strain of TB, again, has been detected among poor populations. And and some of the journal articles I've read, it's, is it driven by HIV infections? HIV infections, talking about impact on the immune system, and is it improving the probability or increasing the probability that individuals with HIV can contract other communicable diseases? Again, you don't know about what healthcare services and the healthcare status of individuals, not only in the homeless population, but individuals coming up through the southern border. And then you've got individuals coming in from the south, southeast, Africa, Caribbean, socioeconomic components. You've got all for orphans and the workforce issues. There's just a lot going on with societal problems in healthcare right now. And it's going to get, I just see it getting worse as time goes on. The long-term impact of age will be the labor supply, because now you're going to start seeing a gap in age distributions because of loss of the female population, especially those individuals during what they consider their childbearing years. You're going to see not only issues with AIDS, but think about what COVID did to the population. Think of the age gap that you're going to have with the millions of individuals that died from COVID. And I'm not even sure in a lot of the labor intensive type world, Far East, Africa, I consider India and in that area, India, China, all kind of lump them into the Far East. But labor intensive countries are going to see the cost of labor rise, and it's going to the cost of labor rising because the demand's there and there's no supply. You've taken out that age gap, so you've kind of taken out. It was an older population that seemed to succumb to COVID, but it also took a chunk out of that middle age, especially individuals trying to raise families. And what you probably will see for these countries to survive from an economic perspective, you're going to see a bump up in technology and automation, less labor-intensive products and markets. And most people are afraid that total economic output may fall, but per capita output and incomes may rise due to just smaller populations. Smaller population, price of labor increases. Overall, in the long run, you're going to have per capita output and incomes more than likely will rise. However, you're going to have output in some of these economic markets are going to fall over time. Used to be cocaine, powder, crack, heroin, marijuana, meth, fentanyl appears to be the drug of choice in the United States now. But think of all the barbiturates and behavioral health type drugs that are floating around out there in the market now. The effects of individuals that are taking these types of drugs, it's going to just add to the drain on healthcare, the supply of healthcare goods and services that can be produced. Drug use impacts the ER. Man, from my perspective, the ER is the absolute last place you want to go for healthcare goods and services. As bad as the ER is, where you have to wait, seems like forever to see a physician or to ever be seen in the emergency room, your alternatives go to urgent care, and most of these urgent care clinics, at least the last couple I've been to, haven't been even staffed by physicians. They've been staffed by PAs. Last time I went to urgent care, I couldn't get in to see my primary care doc and end up going to an urgent care. And I don't know a lot about the clinical side of healthcare. I know just enough to be dangerous, but I knew more about healthcare than that PA did, because, some of the questions that individual asked me, I'm thinking, I know more than you do. And I was giving her the answers. I was answering her questions for her about, treatment. And finally I said, look, I know what I need. Here's the medication I need. All I need is for you to write me a script. It was a Sunday. I said, if you'll just write me the script, I'll pay you I think it was $45. I'll pay you my $45. I'll leave and you can see your next patient. Next thing I know, I had my script in hand and I was out the door. And it's a sad situation when you've got some yahoo like me that goes into a doctor's office, in this case into an urgent care center, and am telling the individual that I am that's supposedly diagnosing me, how to treat my what I think my issue is and how to treat it. And all I'm doing is paying a copay, and I do it just to get the script. That's all I needed. I needed a prescription for the medication, and I got what I needed. I shouldn't have had to go in. I should have been able to just call my primary care doc and say, hey, here's what's going on. I need it. But that's not going to happen, because at that point, they're going to miss that office visit, and they're going to miss the amount of money that they can build a health plan. See what else we've got here. Substance abuse, alcohol, nicotine, illegal drugs, of course, drives healthcare costs in the United States. And it's not so much the initial healthcare cost, it's the long-term effects of using barbiturates and alcohol and nicotine and illegal drugs. You end up with heart disease and emphysema and lung and other cancers, birth defects. People forget about the impact of MVAs, motor vehicle accidents. Think of all of the individuals and the healthcare costs that are driven by somebody that's on drugs or somebody that's had too much to drink, and they cause, vehicle accidents. Is a drug-free America possible? And are consumers willing to change behavior? I can probably answer that for you. And that's, what is they say? The chance of that happening is slim and none, and Slim just left town. So the chance of changing behavior, there's been a little impact on, from a cigarette or tobacco consumption, but I still, see individuals, especially at racetrack and QT and a lot of your gas stations, you're in there, paying for your gas, and they're in, I need a can of snuff. I need some bait. I need some of the, electronic or whatever those e-cigarettes are called, or they're just buying regular cigarettes. So there's still a lot of tobacco used. And growing up in Kentucky, That was our number one cash crop was tobacco. It was, I mean, that was the livelihood. Everybody depended on the use of tobacco. Again, growing up in Kentucky, and you would have seen the same things in Tennessee and in the Carolinas and Virginia. A lot of those states depended on it was a cash crop was tobacco. So I guess at that point in time, we were all happy that people were, driving the demand for tobacco products because it gave us an opportunity to make a profit on growing broiler tobacco or growing fire cured tobacco, depending on which state you're in. But things have changed. One thing they could do is legalize and tax drugs. Can you imagine the amount of tax revenue that could be generated? Not only generated tax revenue, but maybe lower the crime rate, and maybe get rid of black market. All you have to do is just legalize it, put a tax on it, and it might solve a lot of problems. Tobacco and alcohol use drive healthcare issues, drive crime, black market. Again, I grew up in Kentucky and used to moonshine. Had several guys in my fraternity that I was in from Eastern Kentucky, and when they would go home on the weekend, they would come back and the trunk of the car would be full of bottles of moonshine. That was grew up in Kentucky is one of those states that each voting district gets to vote on whether it's wet or dry or whether they can sell alcohol. And even though Bowling Green, the city of Bowling Green, was one of the few wet voting districts in at least in central Kentucky, Lexington, Frankfort, Louisville, Owensboro, it was kind of that was where all the bourbon was distilled, and those were the wet areas in the at least in the state of Kentucky. But you've got a tremendous amount of tax revenue, and again, if you start to legalize it, you end up with not only generating revenues, whether it's local or state revenues, you end up with potentially fewer motor vehicle accidents. Maybe you end up with because alcohol and tobacco abuse especially, you end up with lost productivity, job issues, human suffering, family issues. So I think there's a lot of ways to alleviate some of these issues, and especially alleviate it from a cost of healthcare and driving up the healthcare costs. And then lastly, society, and again, we've gone over this kind of ad nauseum, but societal issues result in ER trauma ward utilization, substance abuse, violence, sexual promiscuity, teenage pregnancy, sexually transmitted disease, homelessness, physical and mental health issues, substance abuse, domestic violence, and decline in family values. And that's why policymakers are doing their, I don't know whether they're doing their best, but policymakers are trying to get their arms around the issue to try to control this. And I think it's going to take some type of behavioral change. And if there is a behavioral change, it's going to be slow. It's going to be slow to impact. Homeless population is transient. And it used to be you worried about the transient population with your VA population, your veterans, because they were a transient population. But now the homeless population is transient. They're moving, constantly moving, and you can't develop any kind of historical database or provide any predictive modeling or anything along those lines with the homeless population, because it is difficult to track them from one area to the next. And I don't know, it's going to be extremely difficult on the government's role, because how are they going to manage their policy decisions, and how are they going to develop these social programs in such a way that are cost effective and actually impact the individuals that really need it. As we've talked about before, so many government programs, so many policy decisions, while in theory they might have been sound, they fall apart when they're actually executed and implemented or put in place, because there's always that portion of the population that is going to circumvent the system, and you'll have these black markets spring up, and that's just going to continue to drive access issues, overutilization of healthcare goods and services. So as you go out into the world, if you decide to end up in a healthcare marketplace, whether it's on the payer side or whether it's on the provider side, you're going to be faced with these issues. You're going to be faced with, how do you ensure that the entity that you work for is going to be profitable? Where do you get your revenue? How do you control cost? And again, payer side, provider side, it's not going to matter which side of that financial coin that you decide to work on. Everybody's going to be faced, everybody in the healthcare marketplace is going to be faced with similar situations, and how do they manage the revenue and the costs associated with healthcare goods and services. With that, we're going to finish up the socioeconomic factors, and I think we've got one more chapter to go through, and I think it's going to be talking about hospitals. So next time you see me, we will jump into, must be chapter 12, and talk about hospitals. Talk to you soon. Thank you.